Very good morning to you, colleagues. Happy that you're able to join us this morning for this webinar. Special welcome to all of you. I know it's a national holiday in Guyana, so Yomanabi greetings to all of our Guyanese colleagues who are online. I am Dr. Shati Singh Anthony, your moderator for today's webinar on critical interventions to scale up HIV care treatment and early linkage to care for people living with HIV. This is a PANCAP webinar in collaboration with the Pan American Health Organization, PAHO. Before we get into the actual webinar, let me share with you a few housekeeping notes. Firstly, your mics are muted, and so if you have any questions as the presentation progresses, I ask that you type and submit these. There is a question bar on your webinar screen, and so you can type and submit these questions. We will take them during the Q&A section at the end of Dr. Omar's presentation. Secondly, we're recording the webinar, and the recording will be shared on PANCAP social media platforms for the benefit of those persons who could not have attended this live session with us this morning. Importantly, by continuing to be in this webinar, you're consenting to be recorded. At the end of the session, you will receive a certificate of participation, but you will also receive a post-webinar evaluation. I ask that you complete these. Your feedback is really very important for us as we continually strive to improve the webinars experience, PANCAP, your webinar experience with PANCAP. At this time, let me go ahead and introduce to you our presenter. 1 second before I do that, I did say that Dr. Omar Sued will be presenting on interventions to scale up, critical interventions to scale up HIV treatment care and linkage to care. And so before I go into that, let me say very quickly that sort of maybe 1 second for me. All right, okay, so let me go ahead and introduce Dr. Omar Sued, and I will hand it over to you, Dr. Omar. So Dr. Omar Sued is a medical doctor specialized in infectious diseases and HIV and trained in Buenos Aires, Argentina. He completed his master's and PhD degrees at the University of Barcelona in Spain. Dr. Sued has worked as an ID doc in different settings, including public and private hospitals, prisons, primary healthcare centers in Argentina, as well as in Spain. He served in some really very high-level positions as the chair of the 16th and the 22nd Argentinian Infectious Disease Congresses, and as the former president of the Argentina Infectious Disease Society and the Presidential Committee for the COVID-19 response. During 2009 to 2012, Dr. Sued served as the advisor on HIV care and treatment for the Pan American Health Organization. And in this position, he supported many countries, including many in the Caribbean, to develop national HIV guidelines and monitor the use and coverage of ARV treatment in Latin America and the Caribbean. He is part of the Treatment 2.0, was part of the Treatment 2.0 and the HIV and syphilis elimination initiatives. Dr. Sued also served on several WHO guideline expert groups, including those for post-exposure prophylaxis, the use of CTX prophylaxis for HIV-related infections among adults, adolescents, and children, in the development of guidelines for the diagnosis, prevention, and management of cryptococcal diseases in adults, adolescents, and children, and in the consolidated guidelines on the use of ARVs for treating and preventing HIV. He has authored more than 300 papers in peer-reviewed journal. And so Dr. Omar is really well equipped with the knowledge and the experience to share with us today on the critical interventions to scale up HIV treatment, care treatment, and linkage to care. With that, I hand you over now to Dr. Omar Sued.
Thank you very much. Thank you, Shanti. It's a pleasure to be with you again. And thank you, all the people from the Caribbean that is connected. For me, it's always a pleasure to be in contact. Can you see the screen, isn't it? So
Yes.
my intervention will be I will start the intervention with a little overview of the epidemic in the Caribbean. The epidemic actually is going better in the Caribbean than in the rest of Latin America. You can see here how the numbers of new infection has been decreasing in the last 10 years, since 2010, and the mortality also has clearly decreased with the introduction of the preventive antiretroviral and with the prevention medication for opportunistic infection and the antiretroviral treatment. However, the uptake of many of these interventions were not clearly similar in all the countries, and some countries need to push a little better in order to improve this figure. Every year we start treatment to many people in the Caribbean, but the number of new infections is still below the new infections are still more, a little more than the number of people we put in the treatment. So the lack of people without treatment is still high. We need to increase this 30% of patients that doesn't have coverage for antiretroviral, and we need to increase also this 40% of people that are not suppressed. But I would like to talk, when talking about intervention, I really want to convince you that we can eliminate HIV. For eliminating HIV, we should focus only on 4 strategies that include increase the diagnosis, treat all the people that we detect, prevent the infection, in particular for those people that are at high risk, and involve the communities, not only in the awareness, in the demand creation, but also in the direct provision of services, in particular with communities that are most affected for HIV in the local context. The situation is different in every country, in every community, in every city, and in the Caribbean in particular, the epidemic meets the criteria for generalized epidemic in many countries, but still there is a lot of sobre-representation of HIV among men having sex with men and transgender women, even when it's difficult to talk about that in some local context. So in order to really achieve this or reach all the people, we should try to give some normalization of the HIV testing. This means try to open more opportunity for testing people, not only focusing in specific systems or in specific populations. So when the people have access to test, we can take advantage if the test is negative to do a risk assessment. And if a person has high risk for HIV seroconversion in the future, we should be offering the prevention of HIV. But if the patient is positive, we should confirm in the same day, initiate treatment, identify advanced HIV disease, and all the people that came to the health services should have advice and access to hepatitis B, tuberculosis screening, prevention, and also all the individualized package that any patient might need. This should be in a continuum, and we call this a continuum of prevention and care. This means that we should focus, at least in this specific step, the number of people initiating PrEP that are at high risk, and the number of people with HIV that rapid initiate antiretroviral treatment. So how we can do to expand testing? Clearly, the testing is very low. You see here the percentage in the region, in the Latin American region, that of the patient that has less than 200 CD4, that range from 44 in Paraguay to only 10% in Uruguay. And this is because the patients or the people has more access to testing in this country with low figures. In addition, 20%, this is the people that know that they are HIV positive. They are diagnosed very late. This means 5, 7, 10 years. But in addition, 20% of the people is not aware of the HIV status because they never had the opportunity or the access to an HIV test. For this reason, today, HIV among HIV patients, AIDS, so the opportunistic infection, still is responsible of 68% of the deaths globally. So we really need to increase the effort in testing, and this can be exemplified here, showing that even though the country report to do 10 million tests in 2021, this figure is nothing if we really understand that in the region live 600 million people. So this means only 1.5% of the sexually active population. And some modeling and some experience, like in Cuba, for example, say that in order to have an impact with testing, you should have tested at least every year 20% of the sexual active population. This means that we really need to increase this test. Obviously, in addition to that, we are not concentrated the testing in people that is having a high prevalence. Most of the 10 million tests are performed in low-risk population like pregnant women, and for the reason in the region, the positivity rate is less than 1%. So WHO say that in high burden setting, like many countries in the Caribbean, the HIV testing should be offered to all the population that appear in any health system. So it's an integral part of any health assessment in any situation. For example, sexual transmitted infection, TB, hepatitis, children, immunization settings, antenatal care, or service for any population. Also, we should have the community-based testing. This means to hire NGOs and civil society organizations in help to expand the testing effort. We should provide, indicate also the provided assisted referral. This means that anybody that is tested positive should sit down with the doctor or with the counselor and try to report all the people that were exposed in the last year and try to contact these people in order to increase the contact tracing. And also this can be done also not only with the sexual partner, but also the social network, because somebody that has HIV is connected with other people that are with a similar risk that can become HIV in the future or can be HIV positive now without knowing. So it's another approach that has a high positivity percentage of results. And obviously the HIV self-test. There were some changes in the algorithm for testing. Usually we used to do the first test and then a second one different from the first one to confirm HIV test and then to start treatment. However, with the increased number of people being tested, it's evident that we need to increase or to be sure that the person is positive. For this reason, WHO recommends that one patient has at least 3 tests before starting antiretroviral therapy. So if the first is positive, the second one is positive, it should be a new HIV test, and then if the 3 is positive, start antiretroviral treatment the same day, which is the recommended test. The WHO doesn't say specifically which one should be the 1, the 2, or the 3. The first should be high sensitive, the second should be high specificity test, and the three can be both. This means that we can use a viral load or ELISA or any other test that we have as we are doing currently in the algorithm. This can be also but if we are not doing viral load for all the patients before starting treatment, well, maybe an additional rapid test can be enough. HIV cell test is really a big, it's a big opportunity for a key population. And Shanti has, I am sure Shanti knows a lot of information about many programs in the Caribbean working in HIV cell testing. The example of Guyana in the last year is worth to be mentioned. But I want also to show the impact. The first cell test program in Latin America was Brazil. They did this website where the people could request an HIV test. It was targeted for men having sex with men, and they could see that 37%, 1/3 of the patients that requested tests have never been tested before, even when they know that they were high risk. And among them, 4% were HIV positive. So clearly it's an opportunity to reach people that usually you cannot reach through the regular system. For pregnant women, the WHO recommends to use the dual HIV syphilis testing. And it's because we are trying to eliminate syphilis, the transmission, maternal transmission of, to the child of syphilis and HIV. So this is a good opportunity for integration. And in this algorithm, we see how to interpret those tests. And finally, for children, you know that we need to use viral load or virological testing. Usually, this is performed 4 or 6 weeks, but now WHO recommends to do this test at the birth, between the 0 and the 2nd day of life, because this information will be critical for children to initiate early treatment. As you see here, using this point of care, the expert machine or the Abbott machine, the PIMA Abbott machine, you have here the increased number of people or children that could have the result in the first day, almost 90%, and the high number of children that started antiretroviral therapy compared with the standard of care, that is to send the DVS or to send the sample to the laboratory or wait until 4 weeks. So for testing, we need to be clear that we need a lot of different multiple approach. We need to focus on people that are in the system, everybody, and then high-risk people or key population that we need to look for them in the community. And also, we need to push and advocate for the introduction for free HIV cell testing and for point-of-care testing for children. The second intervention is treatment, because you know that treatment suppresses viral load, improves CD4, improves quality of life, reduces risk of opportunistic infection, and the end, what reduces is the mortality. And this has improved a lot in the time that I was a resident in 1995, when we were exposed to see a lot of people taking a lot of medicine, but now we know that with only one pill, you can have all the positive impact of antiretroviral treatment with a very low adverse events and very high efficacy. And for this reason now, WHO say people need to start treatment rapid. And what rapid means is the same day to the people that is ready to start. I know that it's not easy for somebody that was waiting a lot of, some doctor that was asking patient to wait to start treatment. It's not easy to change the chip and say, okay, today we will start in the same day. But it's something that we need to start thinking about, because we have evidence of the impact that this can represent. But if the doctor doesn't want to start in the same day, or if the patient is not prepared to start in the same day, WHO say, okay, you can take it until 7 days to wait and to treat or educate the patient and initiate the antiretroviral treatment. But remember that patient usually, I mean, it's not easy for a patient to take the decision of start treatment if you as a doctor are not sure that this is the best intervention. So if you say, what do you think? What you want? I don't know. I am not sure, but you want to start treatment today? If you say that, the patient will say, no, I will prefer to wait to look for more information to ask another doctor. But if you are sure, if you have the evidence and you can share this evidence with the patient, I am pretty sure also that the most of the patient will start. Because the initiation of the same day not only increase the viral suppression, increase the linkage, increase the retention, increase the viral suppression and the survival. You see here how the same day treatment is associated with better retention and viral suppression and with less loss of follow-up and with less deaths. So this came from the meta-analysis, but I also wanted to show this graphic from Haiti program. And in this study, you see here 99% that was offered decided to initiate treatment the same day. 80% were retained at 1 year. 53% has undetectable viral load, but only 3% die compared with 6% that people that die waiting only 3 weeks for start treatment. So really has a very, very big impact. For this reason, you need to collapse in the initial visit while you are doing the confirmation test. You need to you're planning what the laboratory study you will be requesting, what is the information you need to give to the patient, and you need to offer the treatment in the same day. And you can see the laboratory the next week. It's no problem with that. You can continue with that. Some doctors say that the best intervention also is to try to open the bottle and give the first pill in the clinic, because it's like the big step for patient to adhere later with the antiretroviral treatment. So in the real life, if you are working also or detecting patient outside the clinics in the community, you should connect your patient that you shot detected with a clinic to start treatment the same day. But if the patient is not connected or is disconnected, you should have some additional collateral circuit to re-engage the patient and fast track initiate antiretroviral. This was proposed in Africa with a good result and increased the initiation from 50% to 70%. But everybody need to recognize that the life is more complex than this graphic. And this is the diagram of all the different potential social determinants that will be affecting the decision of the patient to start in the same day and go from here to initiate treatment. So many patients will need to go around these issues, and it's good to have this information discussed with the patient for start treatment. So in our clinic, we need to do a lot of things to start using this approach, and this means to convince the doctors to identify what are the competing priorities, to simplify our model of care, simplify the requisition of antiretroviral, to have some stock of antiretroviral in the clinic, and coordinate with other actors for be able to prescribe and deliver the first bottle in the same moment. But also we need to check in the patient level what are the main factors that impede to start treatment, and this is the readiness to initiate. And I am pretty sure that gay man with 26 years old that is coming for an herpes zoster is detected, and he might be very interested in start treatment in the same day because he knows that he is at risk. But maybe a 67, 68 women that is admitted because has some broke leg, and in the medical checkout is discovered she is HIV positive. Maybe she was never or she never saw about that, and she might not be sure about her status. She cannot understand where the infection came from, and so maybe this woman might need a little assessment and a little preparation for that. And also people that have some different health belief or religion belief. Some people that believe that the religion will cure HIV. So some of these people might need additional support and additional education. So how to move forward on initiate HIV in the same days? Well, hopefully the national policy allowed to do that in your country. So then your institution need to be adapted, the patient flow, the paperwork, the buffer stock, and then in the healthcare team, you need to coordinate better with the people from pharmacy and with people from counselors and with the healthcare worker to tailor an approach with time, with empathy, and with confidentiality to ensure the patient can start safe. So, and this is more or less here the same in the yellow is the thing that we can do. You know, we can reduce the visit doing that. We can ensure privacy. We can try to be not judgmental. But there are others that we will be enabled. I mean, the stigma in the society or the social determinant the patient has. Unfortunately, we will not be able to change, but we can change what we can, you know. So the only exception for no initiating treatment in the same day, or at least in the first week, is the presence of cryptococcal or TB meningitis, or the presence of meningitis symptoms. In this case, we need to wait 4 to 6 weeks, but remember that the tuberculosis is not a contraindication for starting antiretroviral therapy. The TB symptoms is not a contraindication, and the positive cryptococcal serum without cryptococcal meningitis is not a contraindication for start treatment. And this was shown in 2009, where this study randomized patients to wait to treat the opportunistic infection or start treatment in the same day. And you can see here, actually was not in the same day, it was in the first 2 weeks, because this was 2009. And you can see here how the survival was better in patients starting antiretroviral earlier. What we should use for treatment, we say the WHO recommend dolutegravir in combination with 2 nucleosides for all the patients. This includes pregnant women, this includes women that want to be pregnant, this includes children more than 1 month of year of age. All these people can start now dolutegravir because all the concern we have initially on the impact in the baby is we could be able to gather all the information and be sure that dolutegravir is the best option in this situation. And it's the best option because it has a lot of pharmaceutical characteristics that made this drug as a more potent drug. This includes the long half-life, the flexibility of the molecule that allow to be effective, and even if there is some resistance to raltegravir, and the high inhibitory quotient. As I say, dolutegravir here is the most potent drug because in 10-day monotherapy, they reduce the viral load more than any other antiretroviral drugs, which has been compared. And this is also evident in the clinical trial. Is better than efavirenz in the single study, is better than darunavir in the Flamingo study, is better than the atazanavir in the ARIA study that was performed only in women, and is better than lopinavir in second line as in the study Downing. There were more than 20 studies comparing dolutegravir with other different combinations, and all this systematic review showed that dolutegravir is associated with better suppression and with lower discontinuation risk, is effective even in patients with high viral load, more than 100,000 copies, and the emergency of resistance on those patients is exceptional. And this is because the higher genetic barrier that, as you see here, we can put this in the laboratory, pass many times in vitro, and no mutation appears, and the drug is working until it's not working. But it's very different from the elbitregravir or rilpivirine or dolutegravir or TTC, that the accumulation of non-precise or resistance will be very frequent. As you might know, dolutegravir is available as generic. It's very, very cheap. Is the bottle for 3 months is less than $15. So it's the cheapest antiretroviral combination that includes tenofovir, lamivudine, and dolutegravir. Lamivudine, dolutegravir is very safe. Lamivudine is safe drug that we know, and tenofovir is safe also. Although 1 every 3,000 people can have some renal impact that improve with the stopping tenofovir. Fortunately, this event is very, very rare and is not very, so for this reason, WHO recommend TLD because the profile, because can be used in children, 1 month of life in all the adolescents and adults. As available, as I say, in very cheap bottles for 3 or 6 months. The issue of transition to dolutegravir in children is important because, as you see here, the viral suppression in children is very low compared with adults, and is something that has to do with the lack of many drugs. So the introduction of dolutegravir for children has been one of the best advances in the last year, that has the potential to increase the suppression to 87%. And for this reason, PAHO is working very hard in order to make the country to have access to this drug, the 10 milligram dolutegravir. And you see here in red all the countries that receive some donation for cover all the children. This donation came directly from PAHO to cover children from 1 month of life until 5 years old. Finally, for recommendation from WHO is the management of the potential failure and the potential resistance. You remember in the old guideline, patients that have viral load that is undetectable need to continue in the same regimen and transitioning to dolutegravir, hopefully. But people that are having a viral load that is not suppressed, if they are receiving efavirenz, they should be switched to dolutegravir as soon as possible to avoid to continue accumulating resistance. But if the patient is already in dolutegravir, we should retest this person, and if the viral load is more than 1,000, we need to consider switch as second line. But if the viral load is less than 1,000, we need to maintain this antiretroviral. We know that the patient will have a low risk of progression, and we know that the patient will not have risk for transmitting because we know that less than 1,000 copy is like undetectable and transmissible. And for the second line, if we started with dolutegravir, we will recommend to use a protease inhibitor, in particular atazanavir or darunavir, because we are trying to avoid the use of lopinavir because the toxicity and the cost. And the people say, okay, I can change dolutegravir for I can change dolutegravir for atazanavir or darunavir, but if I will need to change the backbone or not. Because previously we say you should switch tenofovir for sidobudin, but this is not the case anymore. We know the toxicity that means to use sidobudin. We know the difficulty to take in twice a day, the sidobudin also. And we have some data, in particular the NADIA study, that show that it's not necessary to change the background, the backbone. And this study, patients that were failing to a tripla and that were switched to dolutegravir or darunavir, we will not be this part of the trial. We are looking to this part of the trial. Those assigned to dolutegravir were switched to maintain the tenofovir or switch to sidobudin. And this is what happened after 2 years. We see that most of the patients were resistant to tenofovir and also were resistant to sidobudin, but much more to tenofovir. Look, more than 50% were resistant to tenofovir. And what happened? We see that the efficacy of tenofovir was similar or even much better than switching to sidobudin, because sidobudin was not well tolerated, because sidobudin required less mutation for to be resistant, because we have residual activity of tenofovir. So what is the message here? The message is you don't need to change the tenofovir when you are failing to a tripla and you are switching to dolutegravir. You can switch directly to TLD because you don't need to change or to put this patient in sidobudin. Then we have the patients that are suppressed. We need to transition those patients to TLD. Why? We need to transition somebody that is stable in efavirenz or stable in nevirapine, because we know that those patients, the durability of the treatment will be lower than the durability of the TLD. So if we want to ensure adherence, potency, durability, reduce the pill burden, facilitate the logistic, we recommend to change all the patients that you have or you can to dolutegravir. And we can start with a new patient, we can start with the first line patient, we can start with a stable patient in second line, and then we can increase in switching all the patients with efavirenz and nevirapine and stop buying efavirenz, and then any other patient that has a resistance or intolerance and required dolutegravir. And so this is an example of Belize. You see here when they did the transition program and how efficient were there. They could be able to switch most of the patients in efavirenz and nevirapine to TLD. More than 90% of the patients are now in TLD. And this data is supported by many studies in different countries in Africa, showing that switching to TLD increased viral suppression and it's a clear advantage. What to do if the patient is failing to second line? I mean, we need to think about third line, in particular if your country is thinking about putting genotyping or resistant tests. We need to have access also to drugs that can be useful for patients that can present some resistance. And what are these drugs? Is the third line regimen should include obviously to recycle the dolutegravir, obviously to recycle darunavir that you need to use in high doses, 600 milligrams twice a day, but also to include additional drugs like etravirine or doravirine in order to be able to overcome the resistance. This is also a small part of the guideline, the service delivery recommendation. This service delivery recommendation basically means that we need to adapt to the people. We need to do patient-centered care. We should not be requesting to all the patient to come every 3 months. We need to stratify patients, and those that are stable can come every 6 months or even once a year if they are very, very stable. This will facilitating the site to have less patients and be able to focus on patients that are lost of follow-up and be able to call them in order to re-engage them in care, because we should not be waiting for the patients that are lost to care. We should track them and to re-engage in care. So this is something that that we can start planning to do. Here, in treatment, the point of care are the importance of initiating treatment in the same day, the importance of the viral suppression, that we can achieve viral suppression with the dolutegravir, in particular in pediatric population, that we don't need to switch to sidobudin anymore, and that we need to think about third line at the country level. The last intervention, the prevention. And I don't want to close without mentioning this because it's something that can be easy done, and because it's something that is necessary. This graphic here shows what can be achieved testing and treating all the patients in Australia, for example. And you see here that the incidence will not be reduced enough if we don't include the PrEP. You see here the same scenario with the same intervention. Once that we include PrEP to the 70% of the high-risk population, look how the incidence is reduced more than 70%. So if we want to eliminate HIV, really we need to increase the number of people that receive PrEP in the country. And we can do that. I mean, Australia is doing that, and Australia announced it in Brisbane in the last conference in July that they are on track to eliminate HIV by 2030 because they could reduce 88% of the new infection among men having sex with men in the country. And now also Netherlands made the same announcement last week. So we need to push for the programs, for the PrEP program. The PrEP program is present in many countries in the Caribbean, in Guyana, in Haiti, in Dominican Republic, in the OECS, but in Belize. But really, we need to increase the number of patients receiving PrEP. The option for PrEP that we have is the daily PrEP with tenofovir and emtricitabine every day, or the tenofovir and emtricitabine on demand. This means to use 2 pills 1 hour before, and then 1 pill tomorrow and another pill past tomorrow after one sexual encounter. The PrEP with the oral, daily oral is similar to the intermittent pill, and this was the first study showing some efficacy. And you see here the reduction was not very good, was only 44%. With the seminal study, this was a study in 2010, and after this study, we could be able to identify better way to have people that can benefit more, and identify high-risk people that would benefit much more than that. And now all the different studies show that when the PrEP is, if the people is has a high risk, when take PrEP and is adherent to the PrEP, the efficacy is more than 90%. You see, when you use more of the pill, the efficacy is more than 90%. So really, it's another issue, and in order to convince you the importance of PrEP, I would like to share only this study, that's a PRAD study, the study that the UK required to introduce free of charge the PrEP in the system, because at that moment they provided combined prevention based in condom and counseling. Sorry. So the UK officials say, okay, let's try to see what happened. We will continue doing condom and counseling, or we can, addition to the condom and counseling, add PrEP to this kind of people. gay people, transgender women that hadn't protected anal sex in the last 9 days, that were more than 18 years old. They followed the patient every 3 months, and they were looking how many infections appear in every group, and see there were 20 infections among 200 people in the arm with condoms and counseling. This means condoms might be useful, but are not enough. We really need something additional to the condom. And this additional was PrEP, because in the arm of PrEP, only 4 new HIV cases. This means a reduction of 86% on efficacy of 86% in preventing HIV among this population. So for this reason, PrEP was approved in the UK, and now they can use PrEP in all 1 day, or also in on-demand intermittent PrEP, because the information from the Prevenir and the Hypergay study showing that is similar, the same efficacy, 86%. Remember, the intermittent or event-driven PrEP is 2 pills 2 hours before the sex, 1 pill the 24 hour, and another pill 48 hour, and with this is enough for avoiding. This is the number of cases of people using PrEP and lag. It's increasing, but it's really still very low compared to the number of people that we need to cover. Most of the country are Haiti. After Brazil is Haiti, Canada, Mexico, and Guatemala. And remember that any person that is HIV negative, that doesn't have any acute HIV infection symptom, that is a risk of HIV, is men, women, adolescents, or that is at risk of HIV because has an STI or has casual partner, unprotected sex with people that doesn't know the status, a sex worker, drug abuser, or is asking for PrEP, should be receiving PrEP. And if the patient doesn't have any contraindication, which is very, very rare, those patients should start PrEP. They should start PrEP in the same day, and you can later look for the creatinine in the following visit. So in order to close, let me remember that we need to diagnose, we need to treat, we need to prevent with PrEP, and we need to work with community to know where the HIV is being transmitted, how we can work with the community to reach the people that are hard to reach, and how to involve the communities in the provision of testing and PrEP at the community level. If we are able to do that, as this another mathematical model show, if we are able to do that only in the 70% of the patient, we can reduce more than 66% the new infection in less than 5 years. This was shown not only in Australia, as I say. There are other many cities that are on track to eliminate: San Francisco, London, Thailandia, Malawi, Rakai. This is San Francisco. When they started PrEP, the incidence started to go down. This is also London. You see, when the 3 interventions were available, they started to reduce the number of new cases, and the same for Bangkok. So final recommendation, please, please, please increase testing. Offer HIV test to anybody that you know or you care for and that has never been a test, or that continue having high-risk situation. Sexual network and contact tracing are incredibly effective in identifying people, and you should try to formalize and standardize this in your clinic. In all the HIV negative people, evaluate if they're required to use PrEP or not. If the people is positive, initiate treatment with dolutegravir in the same day. Try to transition all your patients that are not in dolutegravir to some regimen with dolutegravir, because it will have a more positive effect. Please continue using viral load, identifying people that have failure, but implement in your site some system to recover patients that doesn't come to the monitoring visit. Try to implement some specifically the differentiated service to re-engage people in care. Thank you very much. Hopefully it was useful, and don't hesitate to call or send an email or some contact through the network for any discussion, further discussions you want to have. Thank you.
Thank you very much, Dr. Omar. Colleagues, a reminder, if you have questions, go ahead, submit your questions, type them in and submit them to us. But again, thank you so much, Dr. Omar Sued, for a really comprehensive presentation, for providing us with the updated guidance from WHO in terms of prevention and treatment that's really based on new evidence as well as emerging evidence. Interesting, in fact, when you look at the, to begin with, same-day treatment or rapid initiation, the impact of same-day treatment on averting deaths. And I think you had a slide that showed the story of Haiti. So really good evidence in terms of same-day treatment, the evidence in terms of using DTG as the preferred first line, and being able to optimize treatment using TLD as your preferred first line. Also, how we can really take on board DTG to improve the outcomes for HIV in children, and being able to make that transition. I wanted to ask a question while we wait on our colleagues to submit any questions that they may have. And this is in regard to prevention, Dr. Omar. So thanks for sharing all of the evidence on PrEP. Always interesting, the PROUD study and the results that came out from the PROUD study. And you had a slide that showed how many of the Caribbean countries and the Latin American countries are actually implementing PrEP. For a lot of our Caribbean countries, it's relatively new. I think 3-4 years that we have started implementing PrEP. Some maybe even less, like two years. But we have seen from surveys that the populations are saying that if PrEP is available for free, then they will take it. So acceptability for PrEP if free is high, so like in the 80s. Yet uptake is really very low. And so the numbers that are coming in terms of people on PrEP has been slow. And so we have implemented a number of programs at the national level, some at the regional level. And I'm wondering, from your experience, what do you think are some of the more critical factors that impacts on uptake?
Thank you, Shanti. This is a wonderful question and very difficult one. I mean, the context matter, and it will be maybe very different what I say from what is happening in different contexts. But I think the stigma and discrimination continue being one of the most important barriers for somebody that doesn't want to be labeled as a high-risk people to enter in a health system to request PrEP. And for this reason, there are two approaches to this demand creation that we need to do. I mean, we need really to reinforce the communication for all the community about the benefit of PrEP, and in particular for key population in a different way. I mean, you cannot approach key population through the general communication strategy, because if you talk about key population in the mass media or on the TV, this can create more discrimination against the key population. So you need to send clear message to the community about general HIV. So PrEP is a prevention for HIV. You can avoid PrEP with HIV with PrEP. This is for anybody without label or without focusing on a specific population. But then you need to try to enter to the gay circuit and the transgender circuit. This means going to the gay bars, going to the gay blogs, the gay sex application for meeting people with targeted intervention directly there, that they really need to benefit from PrEP. This is first two. And then we need to make it as accessible without the need to necessarily be exposed too much. So what other countries do is, for example, to put PrEP in some pharmacies, PrEP in places where people go for sexual transmitted infection, put PrEP also in the community in NGOs that are more closer to other people. Obviously, in the US, this option for buying PrEP or to receiving PrEP for free through the website or from the public department websites, and something that is so there are multiple approaches in order to do it more accessible and more palatable to the people that doesn't want to go and be exposed in sites. Over.
All right, thank you, Dr. Omar. And I'm happy that you touched on stigma and discrimination in your opening of the response. It still remains an issue. We have a few questions that I would like to share with you. So one participant is asking if you can please talk a little bit about TLD, the use of TLD and renal failure.
Thank you also the question. I couldn't put everything that I wanted to talk, but tenofovir is the component from TLD that occasionally can create some renal problem. And tenofovir is quite safe. Actually, we are having in the world more than, I don't have the exact figure, but maybe 2 million people receiving PrEP and another 20 million receiving TLD. So it's quite safe, and the profile of people that has some renal problem with tenofovir is the people that is receiving tenofovir with other drugs like protease inhibitor or ritonavir, or patients more than 65 years old, or patients that are having some renal pre-existent renal problem. But people less than 65 that doesn't have obesity, diabetes, or renal failure confirmed before, almost never experience any adverse event. In the general population, the risk, as I say, of renal problem is 1/3,000, and the resolution after stopping the tenofovir is almost 100%. So what are the options here? You say, I continue using TLD for everybody because I'm pretty sure it's safe, or I change this to TAF, emtricitabine, dolutegravir. That is an alternative option. TAF was marketed as a drug that is more safe than tenofovir. It's true that all the clinical trials show that some biomarkers of renal function are a little better with tenofovir, but there is not any study, on despite there were 13 studies comparing tenofovir with TAF. No one of those 13 studies could show that TAF reduced the number of renal chronic disease. So there is not a clinical outcome for changing. In addition, TAF in some countries has patent, which make very expensive drug. TAF has been associated with higher weight increase, and recently has been associated also with diabetes and with hypertension. So we are looking the data, and we say if you have high risk of developing renal problem, I mean you have a creatinine clearance of 65, and it's quite low for the people without any previous disease, or if you are a diabetic, maybe on these specific circumstances you can use TAF, but we are not recommended to use TAF for everybody because the concern of hypertension, obesity, and potentially more comorbidity. I hope it was clear. If not, please let me know.
Thank you, Dr. Omar. I am going to attempt to merge two questions here because I have a few more questions. This is in relation to IRIS. And so the question is, in view of these new guidelines on rapid and same-day treatment, how do we deal with the possibility of IRIS, and particularly also in addition, to patients who may be, for example, have TB disease but don't have any symptoms, how do you deal with IRIS? In addition, for persons who have opportunistic infections, the question is, do you, for example, with a TB infection, do you start INH on the same day that you do treatment? And added to that, the question is being asked broadly, what is the place for OI prophylaxis on the same day that you do initiation? Because CD4 no longer is a requirement for initiation, but it's an important element in terms of understanding the need for OI prophylaxis. And so, do you recommend that you offer prophylaxis to every patient until a CD4 is obtained, or are you concerned about the risk of emerging OIs unless,
Yeah, great questions. I think I will start with CD4 issue. The CD4, I know that many countries doesn't have a rapid CD4, so you usually take 1 week to have the results. So in those patients, the decision to provide Bactrim or any other prophylaxis, in particular trimethoprim, cotrimoxazole, the Bactrim, is based on the clinical assessment of the patient. The patient looks unwell, the patient has candida, or the patient has a weight loss. I will provide the cotrimoxazole even if I don't have the CD4, or even if my CD4 is 250 or 300, because there is a clinical impact in the person, and the clinical trial showed that before the CD4, those parameters, in particular oral candida, were very consistent with a high risk of developing PCP later. But there are CD4, there are rapid CD4, there are some VCTEC advanced HIV disease, is a lateral flow assay, is a like a strip that can say you if the patient has less or more than 200 CD4, and this is very useful because if you are in the same clinic in the same day, you have the low CD4 of this patient, you can also increase your research of other opportunistic infection. Are you here or something happened?
Yeah, no, we're here. I just put up a poll because we're running a little.
Great. Because something appeared from my screen. So if you have the opportunity, you could also add rapid tests for histoplasmosis. You can add rapid that is performed in urine. You can do rapid test for crypto that is done in blood, or you can do rapid tests for tuberculosis, the tuberculosis LAM that is in the urine. And these 3 tests should be done in patients with less than 200 CD4. So you can have all the package in the same day and try to initiate not only prophylaxis but also the treatment of opportunistic infection if you identify one. If you have the same day patient, the patient doesn't have fever, doesn't have any other tuberculosis symptom, fever, low weight, cough, or nice sweats, the patient doesn't produce a sputum, or if the patient produces sputum, the expert is negative, you could start the prophylaxis for tuberculosis in the same day. You have an X-ray, you can do the X-ray and check the X-ray and be more sure and give the prophylaxis after the X-ray. The best prophylaxis now is now the rifampicin isoniazid is preferred over isoniazid, because isoniazid need to give given once a day during 6 to 9 months, but rifampicin isoniazid is only you give only once a week over 3 months. So this means you can do DOT once a week during 3 months, and that's it. You need to worry about And in particular situations, you can give also rifampicin isoniazid once, 1 month only, every day 1 month. So you can reduce this 6 months that you used to have you used to have with isoniazid. And regarding the iris question, is remember that many of the iris, the majority of the iris appear in patients that you were unaware of the opportunistic infection. Obviously, tuberculosis is the most common iris that develop after the diagnosis. You start treatment in somebody with tuberculosis, and 20–30% of the patient will have iris. But most of the other iris is patients that are unaware that after started treatment appear with some lymph node or fever, and this can happen 3, 6, more or less 3 months. And the factor associated is high viral load to the beginning, very, very low CD4 in the beginning, not necessarily the identification of the diagnosis of the opportunistic infection previously. This means you will not be able to prevent all the iris. There is one study that was performed for tuberculosis that you can prevent iris in patients with tuberculosis starting simultaneously prednisone. The study is small, it's 200 patients in South Africa, and they give quite high doses of prednisone. They use 80 milligrams, I think, the first day, and then 40 during several weeks. So we don't like very much the study because the risk of the potential risk of adverse events on corticosteroid. Our recommendation is start directly antiretroviral treatment and observe the patient, and if the patient present after 2 weeks some fever or some symptoms suggestive of iris, to start using INES non-steroidal anti-inflammatories, and then if this is not working, escalate to corticosteroid. But it's something that we don't have any evidence that INES, that starting treatment the same day, can be associated with the worst outcome. And actually, what I show you is that the patient have better survival. So in this high-risk patient, the iris is bad, but it's much more bad not having treatment and having a new PCP, a new CMV, a new crypto, because you waited 2 or 3 weeks to start treatment. Over.
Yeah, thank you, Dr. Omar. And I just made a note that Dr. Omar will be presenting more in depth on TB and HIV on the 11th of January of next year. Sounds very far away, but before you know it, we'll be having Dr. Omar once again. I will share the results of the poll shortly, Dr. Omar, but I would really like you to take this final question.
Okay.
One person is saying that BD is planning to discontinue the production and support for both Fax Count and Fax Presto machines, which, as you know, is being widely used in the Caribbean and elsewhere for CD4 testing. And so is PAHO or WHO involved in negotiating with BD on this really important but could be potentially dangerous, disastrous situation? For example, the OECS shifted to Fax Presto last year because Fax Count was being discontinued, but now it seems as if Fax Presto is also being discontinued. So like, what is happening at the global level to help us with this current situation?
Yes, we are working very hard. We're discussing with the producers to see what is the future. Fortunately, the discontinuation for Fax Presto will not be imminent. They will continue selling cartridge during 2024 until July approximately, until they are finished with all the production. And then they will continue providing services to those that continue having kits until 2006. On the PIMA, the PIMA, that is the Alere point of care for CD4, they say they will continue working with PIMA until 2029. There are other analyzers entering the market that we hopefully we will have access in the couple of years. And also we have the rapid test that I mentioned before. So these are the options. There are big platforms for CD4 for hospitals. Does platform from BD continue working? They will not have any problem, but everybody knows that those platforms are very difficult for small volumes. That is better to have. And so probably the best way to go will be to use the rapid test, and that we hope to have more of those tests in the future.
Yeah, thank you, Dr. Omar. Quite a situation to be in right now, and we have to begin to plan for that. Let's take two minutes really very quickly so I can share the results, Dr. Omar, if you can react to them, like in 1 minute.
Okay, yes.
Do you see that?
No, you can tell me. You can tell me.
Oh, okay. So the only option for not offering to initiate ARV treatment as soon as the HIV diagnosis is confirmed, we have 46% of respondents saying the diagnosis of meningitis in cryptococcus and tuberculosis.
Perfect.
Perfect. All right. I will move to the next one. And the question is, to eliminate HIV as a public health threat, we need to. 82% of persons says increase testing, improve viral suppression, and implement PrEP.
Yeah, the other question, I don't see the question here, but what are the other responses?
So those were the two questions only.
Only 2% you say in the second question?
On the second question, no. The second question, 82%.
Ah, okay, perfect. So I could convince everybody.
You did well.
I'm so glad for that. Thank you very much to all that were listening, and I'm really paying a lot of attention. Thank you.
Very good. All right, colleagues, thanks again on behalf of PANCAP and the Pan American Health Organization. Thank you for being here with us today. Thanks again, Dr. Omar Sued, for an always very comprehensive and engaging presentation. As we close, I would just like to let you know that our next webinar will be on Thursday, the 12th of October, and Dr. David Griffith from Johns Hopkins University will continue the discussion on treatment. But this time he will focus on dolutegravir as a game changer for HIV treatment, particularly in the pediatric population. And then on the 26th of October, we'll have Dr. Joel Palevsky from the University of San Francisco in California, who will talk with us about anal and cervical cancer in people living with HIV. And so look out for those announcements. Join us for those two webinars. And again, thank you, colleagues, for joining us today. A kind reminder that you will receive a post-webinar survey. Please give us your feedback. There have been quite a few questions around whether or not you will receive the presentation. And yes, you will receive the presentation as well as your certificate of attendance to the webinar. So again, thank you, Dr. Omar. Thank you to all of our participants, and everybody do have a good rest of your day.
Bye-bye.